knowledge of anatomy, right technique, having cannula at your clinic, using cannula for the technique, and having hyaluronic days, because you have to use it within 4 hours. And above all, if your patient comes up with a message that he has pain, don't take it light, and call him back and treat the complications. Now I'm going to call Dr. Maheen to talk about the nightmare that is the blindness with our aesthetic procedures. So she's going to talk about retrovulvar, perivulvar injection techniques, a lifesaver. Welcome, Dr. Maheen, on the stage, please.
I'm here to basically tell you the technique of the periorbital and the retroorbital retrovulvar injection. Because of all the complications that you've been talking about, because of the fillers and everything, and there is a chance of a reversal. So I'm here to talk about how you actually given the retrovulvar and the periorbital injection. So because the anatomy has been briefly been told by Dr. Sebastian, I would just quickly go through the orbit as a conical structure and the dimensions, and then that will tell you how the injections should be given and how deep it should be taken. So the cone is approximately 42 to 54 mm deep in adults, and the globe sits in the entire half of the orbit, with the axial length in adults being 20 to 25 mm. The retrovulvar space is approximately 25 mm behind the anteorbital margin. The 4 recti muscles extend from the orbital apex and merge with the sclera of the globe. Optic nerve passes within the muscle cone from the optic foramen to the back of the globe within this muscle cone. Thus, the retrovulvar space is immediately posterior to the globe. Ophthalmic and central retinal arteries pass within the fascia of the optic nerve to the globe. So this thing has already been told before. I'll just skip through the blood supply and everything. This has been briefly told as well. So coming on to the technique of the retrovulvar or the retroorbital injection. Firstly, that an informed consent is very important. You can use a topical anesthesia, it could be a 0.5% lidocaine or any other topical anesthetic drug. Injection of a bleb of 0.1 to 0.2 ml of lidocaine 1% in the lower eyelid, skin midway between the central and the lateral 1/3. Use a 25 gauge 1.5 inch long needle with a syringe. You can gently advance the needle into the infratemporal quadrant of the orbit, aiming the needle parallel to the orbital floor for the first half inch, and then aiming it to the space immediately posterior to the globe. The needle can be gently wiggled in the horizontal plane while the patient looks slightly upward to ensure that the globe or the optic nerve are not being engaged by the moving needle. So you can gently depress the plunger to inject. So this picture shows how the position of the initial needle to that of the final position, where you have to take it superiorly and medially so that you are into that retrovulvar space. So coming on to the periorbital injection, it's the same. You can use a 1 inch or a 1.5 inch 25 gauge needle and introduce it through the conjunctiva, and the hand can stabilize the patient's head, and you retract the upper and the lower lid. The needle is passed into the lower conjunctival fornix, introducing the needle at the mid-orbit while advancing the needle along the periosteum. The approach places the needle most distant from the globe. So you can appreciate the difference in between the retrovulvar and the periorbital position, in which the needle in this case stays outside the muscle cone. In the retrovulvar, you go into the cone, which is at the posterior part of the globe, and in this case, you stay out of the muscle cone in the periorbital space. So this is a video that would show you how it's given. So I'll just, to the time that the volume actually comes out, this is showing you what you need for a retrobulbar periorbital injection. And this is the local anesthesia that you use. And everybody here.
Microphone, please.
Hello.
0.75% Marcaine in a 5 milliliter syringe. Use an Atkinson 25 gauge retrobulbar needle with blunt tip for injection. With the patient lying supine, clean the lower eyelid and infraorbital skin with an alcohol wipe. First, check that all appropriate monitors are placed on the patient, then administer sedation. Ask an assistant to elevate the upper eyelid to increase your visualization of the orbit. Palpate gently below the patient's eye to identify the inferolateral border of the orbital rim. The needle will enter the skin at the infraorbital notch, a point at the junction between the medial 2/3 and lateral 1/3 of the inferior orbit. Insert the needle approximately 2 centimeters, keeping it perpendicular to the plane of the face, such that it traverses the path of the orbital floor. Advance the needle until you hear, and possibly feel, a distinct pop. This indicates you have passed through the orbital septum. Redirect the needle medially and superiorly toward the apex of the orbit until a second pop is felt. The second pop occurs as you pass through the sheath surrounding the orbital muscles and into the muscle cone. Carefully aspirate the syringe to ensure that the needle tip is not located in an artery or vein. Slowly inject 2 to 4 milliliters of the anesthetic mixture. Watch the eye carefully. As the anesthetic is injected, the increasing volume under the orbit causes slight proptosis. As you withdraw the needle, inject 1 milliliter of anesthetic to provide anesthesia to the orbicularis oculi muscle. Close the patient's eyelid and cover it with 2 pieces of 4x4 gauze. Gently massage the globe to achieve adequate spread of the local anesthesia. This increases both sensory anesthesia as well as ocular muscle akinesia. After massaging for 1 to 2 minutes, open the eyelid and examine the eye. The sclera should be white. If there is evidence of partial or complete subconjunctival hemorrhage, a retrobulbar hemorrhage may be present. Also, palpate the eye to ensure there is not an increased amount of tension within the globe, as this too may be evidence of hemorrhage behind the eye. If the appearance and tension of the eye are normal, continue to massage the globe for approximately 5 more minutes. This allows sufficient time for the block to take complete effect.
So this is the same thing. And instilling the anesthetic drops, as you can see, we have to give the injection in the right eye. With the help of this alcohol swab, we are cleaning the area,
They said
just like we saw in the
the
previous
retrobulbar needle.
video.
There is a needle which is called retrobulbar needle. So not any needle.
आपके ऊपर की तरफ दोनों आपको खोलिए.
So we ask the patient to look up and we can show a finger in front. The thing is, we give it a needle, a 25 gauge needle. There is not a particular needle for this thing.
There is not. Or
No,
there is.
there is.
It's just this.
There is.
There is a particular needle because
There is a specific-
it is said in the video it's the
Yes, yes, yes.
retrobulbar needle.
Yes, there is a
with a
specific-
blunt tip.
Yes,
Yeah.
yes.
So what we, because we...
But in regular use, if
Yeah.
you are going to do anesthesia, what do you use? What kind?
we use a 25 gauge needle in our center.
And the length of it?
It is, in most of the cases, 1.5 inches.
And it's blunt or regular needle?
It's a regular needle. We sometimes use the blunt, but normally we use a regular needle.
Okay.
Because we, as ophthalmologists, we need it for the anesthesia and for akinesia, for intraocular surgery. We're not into reversals and everything.
Because, I'm going to speak about it afterwards, but it's just that it's important to know from people who do it.
Yes.
Is it a straightforward procedure or it's a very tricky one.
It's not a very tricky one, but the thing is that you should know the anatomy and you should know where you're going, and then the position of the needle is very important. The angle in which you enter,
So
when
it
you take
needs a
it.
learning curve.
Yes, there is an angle.
But that's
and
the
it
problem,
needs-
because if it happens to any, God forbid, to any of us,
Yeah.
we have no learning curve. And in that midst of a situation where the patient is, of course, frantic, and the doctor is peeing on his pants maybe because of what he's done, how could he do such a procedure immediately with steady hands?
The only thing is that you can do it, but the fact that you have practiced enough, yes, contributes a lot. If you're not confident in the procedure, there's nothing much to it actually, because we do it every day, it's not a problem to us.
Yeah.
But the only problem is that when you do it and you get this, from what I've heard, I don't think you see it very commonly. It's a very, very rare thing that you get this emergency.
Yeah,
And then
of course.
once you do that, that means you aren't that
It's a career
practiced.
reckoning,
Yes, so it's going to be
complication,
difficult for you, but not for us, because we are doing it every day.
Yeah.
for intravenous.
Can I just comment
So
over
that's
here?
it.
First of all, what we face is not where you're going to give a local anesthesia in a retropulbar space. So we are giving high hyaluronic acid, not the local anesthesia.
Hyaluronidase.
Hyaluronidase, sorry.
Yes.
And what we do is the local anesthesia is just in the skin, just to go, past that thing. You need to understand the depth of the eyeball. So it's usually about 1.5 inches, which is about 2.5 centimeters so. So that is, you have to go along the bevel of the needle. If you're using needle, the bevel of the needle should be along the flow of the eyeball. Once you go past that thing, then you can go up. Once you are, that thing, that is when you ask the patient to move the eye to make sure that the tip of the needle is not in any structure. Once you are there, that is where you inject. Now, as Sahar has pointed out rightly, we do not have that experience. But remember, this is the difference between the blindness and no blindness. So if you do not do it and you do not have a colleague like Dr. Maheen to cover you at emergency, it's worth trying.
And
It
another
did
thing-
not recover the vision of anybody.
No, most of them were not. There's a paper which says that
They did
if
not.
you do it within the 10 minutes, the time is very important.
Time of an essence. If it is total blindness is one thing, partial blindness is another thing.
Yes, the time,
Partial it can recover.
the time from the injection. But anyway,
Yeah.
let's move on.
Yes, let's move on.
Just
Okay.
one
Yeah.
comment that I was going to make. Rather than going retro-bulbar, you can stay outside the cone and give a periorbital injection. That would be, I think, safer for you people, because we all
Yes,
need
I
to
guess
do
there
is
is a
dissolve
paper,
that
yes.
HA and through this enzyme,
Yes,
and then that's
there- there is
so
a
I think
paper
periorbital
published on
approach
that.
would be better
Yes.
for you. And,
Injected here. Yeah.
thank you.